miss. You're going to be stuck with nursing instructors, most of you who, Josh is not here, who eat their young, who don't like you, who are nice people, but you're going to have to battle. All right, goodbye. An interesting unit we begin. This is, it, to me, I think that the most common areas for infection, and I try to do them in order. With wounds is odd because wounds kind of overlaps a lot of them. They can underlie a lot of all those things. But what I am recording now. Just looks that way. Yeah, good. Okay. So when I look at this, I think that I'm not sure if it's number one. I think respiratory is still number one. Skin more or less, and it overlaps these. I didn't put it in skin, but I'll put it in for you when we do the genital warts because warts are part of skin as well. And it wasn't for whatever reason I must have zoomed right past it when I was doing the presentation. But I'll add that when we get to the genital warts, which is very, very important in this. But urinary tract surely has got to be up there, and so it's rampant. It's a little better controlled, I think, in a lot of ways today than it was when I entered the medical field 50 years ago, because we had epidemics of sexually transmitted diseases in gonorrhea and syphilis. Okay. It has not left us, but I think we have a slightly better understanding, and oddly enough, we can attribute to some measure of control vis-a-vis fatalities with regard to the advent of HIV and the eventual diagnosis, where people all of a sudden became aware of the fact that they, even though they should have known it, that they could die from sexually transmitted disorders. But now all of a sudden it reared its ugly head and they saw people dying. And after not understanding it, and we'll get back into that again, okay, they all of a sudden, now we understood the transmission, and all of a sudden the concept of protection became much more available. There's so much to it sociologically, is the way I would describe it. So after that little sort of wordy narrative to introduce it, let us begin. They don't have any little clever anecdotes on this or anything like this. And what they, on the Cowan sequence, as they do with Nestor, which usually gives you a little thingy about it. Okay, you're doing repro now, physiology and anatomy. We don't have to go crazy over this. And urinary you already had, right? Most of you, we've had me, obviously. We've that ship sailed. So they're very, very two distinct things. And when we talk about genital urinary, we have urinary and we have genital. And anatomically, because of the distinction, is a big player. Because of the proximity of those two systems in the female, and the fact that it's somewhat more remote in the male is a big difference. So, and we know what they do. Yeah, remove substances, form urine, blah, blah, blah. Reproductive functions, mainly in reproduction, etc. So all of those things are there. The kidneys, okay, you already did this. Metabolic waste, filters, and basically they're doing the job, and everything else is a conveyance. Ureters, bladder, urethra are basically how it flows out of the kidney, storage, and get rid of it. The interesting thing is that's where most of these problems begin, because of the anatomy of the system and the utilization of the system is a shared system in the male and a very closely together system in the female. And so I don't want to go crazy with all of that type of stuff that's there. You already did this anatomically, you saw it, yeah, the right one's lower, all that. There's a certain inherent defensive and urination and the flow of urine. So ultimately, and I say this all the time when I do the physiology part of the program, it's for most of these systems, it's a plumbing problem. If it gets stuck for whatever reason, whether it's infection, whether it's a blockage, things move back up. So it's like backing up. You can imagine like backing up a toilet, if you want to think of it in sort of a gross way of thinking about things that are there. And you're shedding cells, and microbes are going along with the cells. I'll buy that. Normal microbes play a very important role, much less so in the male than in the female. And the key player in this 101 is a very interesting organism. I might have said already too, it's called lactobacillus. The principal defense to infections and disease in women during their childbearing years. So It's mucus, before the availability of the mucus is the protective area pre-menopause, postmenopausal and pre-puberty. During that stage in between, it's all about lactobacillus. Lactobacillus is normally found. It's a very fragile bacteria. It thrives. Okay. It thrives on glycogen and it ferments like crazy. That's where it gets its name, lactobacillus. It makes lactic acid. Why is there so much glycogen? Estrogen creates an abundance of glycogen in the female urinary tract and reproductive tract areas. So that acidity is the big player. So all of these, there's all sorts of neat little things. So you have to have bacteria that are adapted, or for that matter, viruses that can adhere and enter fairly easily. And so all of that plays a role in it. So the big players, with urine itself, is acidic in nature. It has a certain amount of lysozyme. It has something that interferes with iron binding in bacteria. You need that iron to grow, called lactoferrin. You're already all familiar by this time in your careers with IgA, which is in all of our secretions, which is sort of generically a defense. So that's important. That was mostly the female. Will go on to the male. We know what it does, etc. You already probably covered or will cover the anatomy. Yeah, same deal. Most of the problems that we see really are more in the urinary, in the shared area of the urethra, where really the problems are. And from that, they get into other structures. We see it less so. To me, it's comparatively rare that infections make their way into the testes and epididymis area, because once they're in that area, now you're looking at infertility, uh, surgical intervention of a major part, all this. So I'm not going to go crazy over it. Testes make the sperm and the hormones. Epididymis basically is storage for growth and development of the sperm. They are stored in there at ejaculation. That's where they come from. They make their way by the vas deferens. This is where the system shares. In something called the ejaculatory duct, we begin to see the vas deferens picking up secretions that are very important from the seminal gland. That seminal gland, about 70% where semen gets its name, as they merge together. Immediately after they merge, they enter the prostate gland, which gives another roughly a third of the secretions. The milky white stuff plays a role in activating the sperm, all that good stuff. And what happens is that's where the urethra meets it. So now you have this confluence of structures, two glandular entry points, the vas deferens, which are now all of a sudden magically, all of them become what they call the prostatic urethra. And that's it's now we're in and around this area where things start to get interesting. Now it's a shared system, unlike the female, where you have reproductive material and urine passing through the same tube, but a variety of structures preclude the two of them passing simultaneously anatomically. And if you go into that in A&P, great. If you don't, great. Whatever. Okay. So, and in men, the prostate gland is a real problematic area, just like breast in female. They're glandular tissue. They are, because there's so much activity associated with them, I believe, they are really predisposed to problems. Breast cancer is much more so, and I'm sure there's a little unit on this in this, or there will be, from breast cancer, extraordinarily common and tragic. And prostate, really a function of aging, because the whole system starts to break down 50s, 60s. And so, you weren't here, but in October of last year, I had prostate surgery, okay, for enlargement. And they lasered it, and it was very unpleasant for the last. Procedure was easy. The recovery was a pain in the neck. You've seen all this, all right, flushing action, blah, blah, blah. The female one you've seen, we're not going to rebuild the wheel. Okay. The cervix by definition is a neck, but it really is, its discussion is more about in this area. The lower 1/3 of uterus, that where the area connects with the vagina and really becomes a common area. It's almost like an area where things can adhere and attach. So look at the defenses associated with the female. Limited with mucous membranes, has the protection of secreted mucus. Major non-specific defense, pre-puberty, postmenopause. IgA, comes along for the party. All about the pH, brought about by the release of estrogen, which occurs at puberty, stimulates glycogen. It's just what I was mentioning to you guys before in the vaginal mucosa, which certain bacteria, read that as lactobacillus, ferments into lactic acid, and the pH is rather acidic. That's a significant degree pH, 4.2 and 5. And so prepubescently, little estrogen, pH 7. So vastly different changes occur because of that. Because of that change in acidity, you have a limited number of players, or more specifically, a different array of players that can act as normal biota or normal flora in the area. And and see what their role is different because it's all about not harming the fetus. The context, and I said it to my lab the other day, Mike, the context I think to best understand not just your genital urinary infections, but reproductive things in general, is to understand what it's about. It's supposed to be about conception, fertilization, implantation, etc. That's if it's working normally, those events are more likely to occur. Obviously, they don't always occur. It's to me that's sort of the way focus yourself, and then we look at the what goes wrong. Again, my context, having 3 adopted children and never having had children biologically, is from the infertility side of things, which I understand fairly well. Okay, that's my knowledge, and it's by no means the infections I'm knowledgeable about. The system is by no means my strongest system, like things like bone, which I know. Let's see. The lower urethra has a well-established microbial that's close to the exit, where the urinary tract, as you get up, there's less frequent. We're heading towards sterile. Different between men and women. So now we're getting into the anatomy. Short urethra, close proximity to the anal opening, big problem. So we end up the most common infection, non-sexually transmitted, and there are 2, are standard lower, or what we call urinary tract infections, which involve contamination by some type of organisms that are common in the anogenital region in women. So most of the time, they're organisms that are frequently found in feces that come there. Mostly it's E. coli. Guys you work with in the lab, E. coli, Proteus. When you didn't work with in the lab, that we're seeing a lot of called Staphylococcus something, but not Staph aureus or Staph epidermis. The name will come to me. I'm sure it'll be in here. So it's a little bit different. So it's a pipeline for bacteria from the GI tract to the bladder. It's almost unavoidable, just the very fact that they're there. And think of the activities that we do. So does hygiene play a role in that stuff? For sure. That's perhaps the most common. You're just going to see a zillion of them in nursing with catheters. A zillion of infections with that. The other is the vaginal yeast infection, which comes from alterations in the normal flora, particularly that our old buddy lactobacillus, because the yeast, Candida albicans, by far and away the most common, is normally there. And we see a lot of problems associated with that. Anything that alters, and there's a lot of things that can alter it. Certainly, we talked about this already, broad spectrum antibiotics playing a big role in that, but there's other things that can play a role as well. Concomitant to other infections, skin conditions, hygiene's always going to play a role, etc. So, penis, aerobic Pseudomonas, you're already familiar with from the lab. Staph, it's just an exposed tissue. Uncircumcised, a little bit different. Okay, and so that's something you typically don't run into if you're working in this country for the most part. Okay, same residents mentioned previously. Microbe-associated STIs become long-term residents. Interesting. Circumcision has a large effect on the normal biobes. Okay, and again, more diverse. You want to think of it this way. Occasional trespassers in the female, or possibly permanent residents of the upper female reproductive tract. And again, without going too crazy about that, we're going to get to the lactobacillus again. So again, the pH going to acidic as we reach into childbearing years, the way I describe it. Lactobacillus, the big player in this, combined with the acidic environment, is really a player. Candida is there, pretty consistent. Candida tends to thrive, and fungal infections thrive once there's alterations, when there's less of the other bacteria available. So, and I'm sure I told you, I occasionally get, I sit there with pills in my, on my desk in the bedroom that are antifungals for thrush, which is something you're going to see, which is a mouth infection because of the immunosuppressant agents that I take. Just every so often it rears up the ugly head. And you can go through that, go through that, go through that. And the flushing action. Interesting thing. So when urine is not flowing, it's interestingly something that organisms can grow in. Infections of the bladder, specifically, we look at both urethritis, the start, and cystitis, the bladder. In the male, urethritis is more common because of the elongated urethra. In the female, the bladder, because of the short urethra. Okay, much more common to go in there. Okay, it's if something reaches to the kidneys, we have a very serious infection. And so for a long time in the male, when they looked at inflammations of the urethra, they were nearly all sexually transmitted. Because gonorrhea was so common, we actually called them gonorrheal urethritis and what was called NSU or NGU, non-specific or non-gonorrheal urethritis. That we didn't have the capabilities in the lab that readily to identify things like chlamydia or trichomonas. It just wasn't that easy. They fell into two areas and you treated them different because gonorrhea was by far and away the big player. So they'll look at things that are considered sexually and non-sexually transmitted. Today, it's mostly about the non-sexual ones. Can they play a role in sexually transmitted disease? Yeah, because when somebody has, doesn't matter if it's a man or a woman, when somebody has an infection in that area, boundaries are broken. I mean, these itises mean inflammation of tissues damaged. That's a boundary. Okay. Linings are more exposed. Everything, sort of universally, what we see in this is if you have an existing problem, whether it's post-traumatic or post-infective in nature, you're much more likely to get something else. So we see this a lot, okay, particularly in a clinical setting. If you're working in an area, as a doctor or a nurse, in an area where you have a lot of people coming in with problems, you're going to see that you see an abundance of problems. People have multiple diagnoses. So they'll have had, historically, you can look at their chart. They've had herpes infections. They've had HPV. They've had chlamydia. All of those things are damaging structures. And if they're active, they're much more predisposed to that. There was a slide in this PowerPoint years ago, and I was teaching over at CCAC North. And I had, this was a very bright student. You have a lot of non-traditional students at community colleges, folks who have life experience. And typically the ones I was teaching were going from working in a doctor's office to being a nurse or something. Because they back to school, 25, 35, 40. And she'd worked in a doctor's office in Fox Chapel. My kids went to Fox Chapel. They all graduated. So I know the population very well. And we were talking about somebody passing on herpes, okay, and potentially killing a baby as it was being born, which does occur. And she that would never happen. No woman is going to go to, without prenatal care and get that addressed or treated. And I'm looking at her, what are you talking about? I didn't quite say it that way, but my eyebrows probably did. I mean, yeah, in Fox Chapel, it's probably not going to happen. Okay. And they're going to have prenatal care. We had people come into the emergency. We had kids come in the emergency room who were telling their parents that they were just gaining weight and they were crowning by the time they came to the emergency room. It's the real world, everybody. Depends on where you're going. If you're going to work in an upscale community, it's unlikely you're going to see some of this stuff. If you're working in a third world country, you're going to see all of it. Just be aware. I mean, because my first wife was very into because she was the head nurse in the emergency room at the time. Here in this inner city hospital in Philadelphia. And everybody's crowding in. They want to see this poor teenage girl having a baby. Oh, great. Nevertheless, signs and symptoms: pain, frequency, burning. And this is consistent, men and women, that we see with urinary tract difficulty emptying, pain on urination, discoloration of the urine, all of those kinds of things. Cloudy, when you see cloudy white blood cells. And because the lining is damaged, you see trace amounts of blood, which is different than gross hematuria. Gross hematuria is red. But when you see discoloration, different. That usually means microscopic. And it's an easy dipstick that you can do in an emergency room or in a lab or in an office and find out low-grade fevers and nausea. When you descend into the kidney itself, flank pain, low back pain, fever. I mean, you're seriously ill. There's no question about it. Okay. Typically, the urinary tract infections, much more so, and certainly in the female, is typically the bladder. And there's a lot of things that can do it. Famously, they used to talk about honeymoon cystitis when people who were not back in the day as sexually active, and then magically, became highly sexually active, as you might expect on honeymoon. That type. So it was mechanical irritation, and that allows some of the normal flora perhaps to invade, or some abnormal flora to invade. So different types of ones. And now they have a distinction because if you recall, when we talked about a little bit about epidemiology and healthcare associated or nosocomial infections, that they still, to this day, even though the numbers have improved, with a more appropriate and more intelligent approach to catheters, we don't see the long-term catheterization. Healthcare settings and those acquired outside. So catheter-associated UTIs, okay, minimizing the use of catheters and it's been around for a long time. 95% of the UTIs are caused by normal biobes of the GI tract. And here's E. coli. Still number one on the hit parade. These are not necessarily the strains that you worry about or you hear about in contaminated foods that cause people to die or become seriously ill. It's not the 0157H7 E. coli. It's normal E. coli. This is the one whose name just escaped me, Staphylococcus saprophyticus, and members of all the Enterobacteriaceae, if you don't recall the name. Enterobacteria or enteric tract, GI, Klebsiella, Proteus, etc. Common. So that's where they come from, that we see there. And catheters have changed from a standpoint of how they're handled, how frequently. There's more use of limited or straight catheterization as opposed to the long-term, which was the status quo, indwelling Foley catheters for long periods of time. That's my understanding. Community acquired. They're typically not transmitted, okay? It's just something, there's a contamination, okay? And again, it's anatomical. Recurrent. It doesn't speak to anybody to a behavior. Some people are just unfortunate to have these things. Some invade deeper tissue, avoid being killed by antibiotics, and they can reemerge. So some people are just unfortunately prone to it. I saw so many, when we get to the yeast infections, I'll tell you the same thing that I told you before with regard to, I had all the diabetics, better part, about 2/3 of my patients were diabetics. For all of the female players who were there, whenever we started on antibiotics, most of them I had a little Post-it note or a sticker or a dot on the chart. That dot said to me, make sure they get a prescription for diflucan to take orally with it, because they're going to get a yeast infection because they always got them. So sometimes it's knowing that there's a persistent nature to certain things. I don't think this is correct. Are you going to run into nitrofurantoin or macrobid? Yeah, I think that it is still more common to this day to use Septra, and there's a folic acid one, the folic acid inhibitors one, Septra, and the other one is coming to me. They're available generically. They're combination sulfas. You take them twice a day. they're cheap as chips, as our British friends would say. Okay. I had a very bad soccer day yesterday. I think Lissandro Martinez might have popped an ACL. Well, there's no Steelers until, and the Penguins tanked. No other way. Get a goal. Bactrim, etc. And so they're easily taken. They're constantly used. There are some allergies to them. Macrobit and still certainly used. You may or may not be familiar with this. This is available over the counter. Okay, Peridium products. They soothe the urinary tract. So when I had prostate, you use those. The problem with them is they tend to change. They create an orange color in the urine. Okay, that are there. So you could, anybody can buy them. You know, every store, grocery store, pharmacy you go to will have them. So it's much more symptomatic relief, and it's the change, the orange to a reddish color. Okay, and you typically, if these do not work, and sometimes the first line of these, particularly in people where you're have had them more frequently, would be CPRO. When I see my urologist, whenever he's doing any kind of a procedure, CPRO is or something in that family, or that drug of choice. You can even do it on a prophylactic basis. It's unlikely you're going to see this. They always bring it in. Again, non-sexually transmitted, mostly from breaks in the skin for people who bathe where animals utilize the water for bathing, urination, whatever. Okay, I've never seen an animal in the bathroom. My dog goes in there, but he wants to get into either the cat litter or the garbage can, as in this morning. You're not snacking in there, are you? He's a dog. So, and it's worse. It's historically, so it's caused by a spirochete. It's immunological. You can get all terrible. There's something called Weil syndrome. I don't even know if you have to know anything about it. I will not ask you a question about that. If I have a question, I'll take it off. So it's usually something that passes for most healthy individuals. Again, it's the type of thing, if you're doing a medical mission or going on, what did you tell me? The nursing thing they're doing, what, Colombia, Ecuador these days? Right? Is that where they're going? Yeah. This is the kind of stuff you got to be watchful of. It's all about the water supply. So it's a spirochete, Leptospira interrogans, in humans and animals, lots of different serotypes, et cetera, et cetera. Contact with broken skin or animal urine. There'll be an oddball thing, like we'll see there. Early treatment with doxycycline, that's fibromycin, cephalosporin. Delayed therapy is less effective. Okay, so the type of thing, and this is a consistent, and we see it in Lyme disease, which is spirochetal, and syphilis, which we get to in this unit, which is spirochetal. Earlier is better. They're very immunologic. And once the immune system starts to damage structures, if it's not treated right away, we have problems. Okay. These are, again, non-sexually transmitted. The distinction, we use the term vaginitis, vaginosis. Prostatitis is self-explanatory. It's just inflammation. It can come from a variety of sources. Frequently, that's where in infections, we do see an infective origin in male. Perhaps it's more often hygienic than anything else, or it's because there is some problem with the urine not passing satisfactorily in some way, shape, or form. But when they say vaginitis, the itis means inflammation. Usually that's the candidal or yeast origin. That's the classic vaginal yeast infection. Vaginosis means, osis means condition of, when you see that suffix. And what that typically means, it's long-term and chronic. And this particular condition is very unpleasant, more common than you think, and has a lot of unusual factors that are associated with it. So it's usually a multifactorial infection, and they'll get to that. So that's where the distinction and the presumption is they are not sexually transmitted. The reality is that if someone is suffering with these on an acute basis, they would be best advised, both for their own protection and for their partner's protection, to not be active. So, isn't that terrible? Now, this is a relatively new publication. See, I think if I was to speculate about this, now see, they're taking along with these things. They blame these increases on budget cuts and local clinics. In a recent year, clinics closed altogether. I suppose you can make that argument. I just wonder, since people understand now that HIV is treatable and that these quote unquote diseases that could be lethal are more treatable, people are less inclined to use the typical barrier methods, to use condoms or to use some type of barrier method. Okay, and maybe that's true. Just like it's interesting because I certainly have no expertise in this area to talk about the sociological implications, like, and human behavior and things like that. Just the way it's the way it is, and I may probably said this to you before. Forgive me for saying it. This is what I believe. Okay, and I think it's important. Women are much more cognizant of reproductive health, particularly if they want to have children. Okay, so they're much more aware of that. They're more likely to do self-breast exams. They're going to get regular gynecological checkups for the most part. Guys, for whatever reason, don't. Guys don't want to go to the doctor with a problem in that area. The male ego is much more fragile, my experience. You don't want to go there. Oh, I'm having a problem in that area. Oh my God. It's what they are. It's true. Do not quote this. As long as the equipment is working, guys are happy. Just say. She's writing this down. You're writing that down. He said that. If I get in trouble, it's your fault. Sadie would do it. Yeah, I'm sure. Don't even start. It's the reality of the situation. I'm trying to be honest with you. Okay, so they're going to get into these, and we're going to start to see these a little bit more. So it's a little out of sequence. Let me see if they. I don't want to. I wanted to do those other diseases because they're doing these discharge diseases and not doing the others. Hold on. I'll flip through, having done this a lot over time. But I downloaded the other one. So I mean, same author. I mean, it's not same author, but same publisher. So here they're talking about this is the cystitis nugget that you can see there. Antibiotics different. So you can see the AIM information. And I wanted to get to the non-sexual diseases. They almost the same order with leptospirosis and the different variations. Here, we'll give you two. The vaginosis condition of, because again, the presumption is non-sexually transmitted. And then I'll get back. There is a discharge. The bubbly nature and the odor, okay, gets this, and it's very stigmatizing. Particularly in the concept, I would think, of having some type of intimate relationship with someone else. Now, they think that would be stigmatizing. And yeah, it could be. The problem is we think that odor and then that bubbling suggests an anaerobic organism or organisms. They've never really put together what there is. There's Gardnerella, which is an anaerobe, is part of it. So the treatment is usually metronidazole, which you're going to see recurrently here. Flagyl or metronidazole, very effective, very useful antibiotic or antiprotozoan. They feel this is more bacterial in origin, is very effective and works. It's not long term, okay? Half the cases are asymptomatic, But the trouble is if it's not treated, and what happens with pelvic inflammatory disease, the inflammation of all of those structures in the female, they're so intimately associated and relatively, and you don't have the, you want to call it the luxury of, the long urethra is, once it gets through the uterus, it's in the tubes, it's in the ovaries, potentially it's into the peritoneal cavity. It's a whole lot different than the male anatomically. And PID usually results in order, ectopic pregnancies, early onset menopause, hysterectomies, infertility, consistently. So once you get to that stage, and a lot of times in the big trouble with it's asymptomatic until it gets to be severe. So for people who are sexually active, or people who have certain predisposing conditions, or even have something like this, they need to get that looked at on a relatively frequent basis before it ascends and becomes effectively a 5 alarm fire where there's no coming back from it. Okay, we don't know the causes. Yeah, decrease in lactobacillus, lots of different bacteria that have been cultured, loss of acidity, disruption of microbes. They call these clue cells. They're large. They've got a lot of microorganisms in them. They're not technically inflammatory. And again, the aerobic area of it, not well understood. Sexual abuse of children. So there's other factors. Pregnancy, multiple partners, sex with other women, new sex partners, IUDs. So whatever is the most common means today, and I don't know. So I mean, I'm not conducting a survey, but there's always been problems associated with it. No proof of sexual transmission. Again, the risks, and you're going to see this recurrently in any of these descriptions or PowerPoint descriptions, the risk of getting other problems and other infections magnified dramatically. That's the vaginosis. Respond quickly. Again, the choice is certainly metronidazole. Very important in pregnancy. And this is another consistent thing. Probiotics, yogurt, acidophilus products, those kinds of things that are so easily available today. They're constantly available today. They're very useful. Most of them are very, very rich in agents that either contain or will restore the lactobacillus. Okay? And it really doesn't impact from a standpoint of the male that's there. This is candida. Candidiasis, this is not 1000 magnification. This is high dry, 400. Anything would stain. If this is a gram stain, which probably is, these you would not see this definition in cocci or irregular shaped cocci at that magnification. You got to use oil to make that dye. These are easily visible. Okay. And how do we know they're yeast? You look for little things there like budding that are there. You can see a hyphal strand. That's the distinction, which you don't see that in bacteria. Bacteria don't, typically, very rare that they do budding. Intense burning, itching, so it's inflammatory. Red and swollen. The discharge is more white than grayish, I would dare say, because albicans, the name for Candida albicans means white. So it grows white in a culture plate and classically use that. It's normal. Third, maybe as much as 50% vaginally in our mouths for all of us that are there. Usually limited, disruption of a variety of ways, as you can see, particularly antibiotics. Okay, it's an inflammatory response, late pregnancy, poorly controlled diabetes, use of certain kinds of oral contraceptives, antibiotics, hormone replacement therapy, which is another thing that's utilized post-menopausal. My first wife was on it with early menopause. A lot of non-predisposing factors, is not spread person to person. So that's why we look at it that way. And another one, we do this in wounds, but I'll throw it in because it's in the PowerPoint, and that's toxic shock syndrome. It's both staphylococcal and streptococcal, and none of you were around in 1980. Sadie possibly. Pick on her, she's not here. Riley in absentia. In 1980, I had just started in practice, and I started in June of 79. And all of a sudden, this went nuts. They had developed a tampon that was an OB was a manufacturer. It was a high absorber. It was a convenience tampon, so you didn't have to change it constantly. Little did they expect or know that the makeup of the material and the high absorbency and leaving it in for such a long period of time would effectively form a culture plate for certain types of staph and strep mostly. And some of them produced this toxin, and this toxin was one of these megatoxins called a super antigen. So it activated your helper T cells like crazy. Okay. And they produced all sorts of chemicals, and your whole immune system went off the charts. And it became like shock because when that happened, blood vessels dilate, blood pressure dropped, people got sick, all of those things. So not a new disease, but emerged due to technology and behavior. So when they lowered the absorbency and changed it, look what happened since then. Now, mostly we see toxic shock syndrome in wound infections much more frequently than we do anything genitourinarily oriented. But for the sake of, and a lot of women stopped using tampons for several years until they did a lot of long-term studies and gradually. So that alone did a number on the industry. That's what happens when people from a society we use this high temperature headaches, muscle, bloodshot eyes, all this type of stuff. TSST, which is toxic shock staphylococcal toxin 1 and other related toxins. Blood soaked tampon. Okay, but the toxins, if the toxins that do this, it's called a cytokine storm. All these chemicals released by the T cells. Okay, 75% from staphylococcal. Again, not spread person to person. There was something that was out a long time ago that they took off for this reason called the sponge. It was a contraceptive sponge. They did a Seinfeld on it. Just, this will probably get me into trouble. Elaine, you familiar with Seinfeld? Anybody? Okay. See, Elaine, the Julia Louis-Dreyfus, brilliant comedian lady. When they were starting to get, she stockpiled all the sponges because they were taking them off the market, and she started to describe guys as sponge worthy. That was the joke. It was a show about nothing. Soup Nazi. Just you guys have you missed too much. I realize it was gone before you were born. Okay, just say. So I thought I would throw that in for the sake of completeness. I only do it in classes I like, which brings me back to the other PowerPoint. So let me backtrack a little bit. So and the way I classify them, I like the way Nestor classifies these things, which is they do bacterial, then they do viral, then they do protozoans, then they do fungal. Here, and to be fair, this is a very common way of classifying things that are there. Okay, they classify them as things like ulcerative diseases or discharge diseases. So when they talk about this, a discharge means there's a discharge coming out of the penis or the vagina. And that discharge is therefore culturable, able to examine microscopically, gram stain, whatever you're going to do with it. And so there's a lot of diseases, and the most common ones, gonorrhea, chlamydia, trichomonas vaginalis, all in this category. There they are. Okay. If you statistically, I would think that chlamydia is surely the most common bacterial sexually transmitted disease. Gonorrhea, less so. It never used to be. It was the most, but it was much more painful, and people became much more attuned to treating it. Finally, Trichomonas vaginalis, which is a protozoan, which is why we learn about the protozoans, is surely statistically the most common of new cases every year of sexually transmitted diseases. What happened, and again, if you look at that chart about reportable diseases, it's not reportable. It's that far along where gonorrhea and chlamydia are. Why? What about herpes and HPV? They're viral. They present differently. But the reality is trichomonas, it's new cases, herpes and HPV add to cases because once you have it, you can't get rid of it. Whether or not it affects you again is a different story entirely. Cause an increase in discharge in either male or female, transfer to new hosts, contagious. When the fluids, where they live or reside, and typically, and obviously, whatever the component is, typically if there's open sores, there's a frictional component, etc., all those things. Typical signs and symptoms. Gonorrhea first. It is the most painful. It's the one that really has a pus-like discharge more than anything else. That is there. There's a troubling picture in the Nestor PowerPoint, which I will probably not show you today. I don't want to spoil your weekend. Okay. Urethritis, pain. The discharge is pus-like. It's very yellowish. Okay. The asymptomatic aspect is much more female than male, though less so than the others. Most cases it's like that because it hurts so much people get it treated. It had in the old days it was called the clap, which had something to do with clapoir, which I guess was a bedroom in a house of ill repute. Just saying. I could have used another term. Brothel. It's a great song from the 60s called House of the Rising Sun. It's a great song. And it describes a brothel in New Orleans. Okay. In most cases, it's limited. I'll buy that. But if it spreads, we got problems. Scar tissue, significant problems. In both the male and in the female. Okay. Both typically during intercourse, certainly in the female, mucopurulent, mucus and pus, sometimes a bloody discharge, again, painful. And there's the ascending of it. And when you hear the term salpingitis, that's referencing the tubes, the fallopian tubes, are where the hysterosalpinogram is when you used to inject dye into those things. And it leads to this PID, inflammation, can become mixed with other bacteria, buildup of scar tissue, sterility, ectopics, and really significant. The big thing with regard to this, I know we're just about out of time, is gonorrhea attaches easily. If it's in the bloodstream, if you see an infection in a joint in an individual without trauma, all of a sudden a joint swells and you tap the joint and pus comes out, gonorrhea until proven otherwise. Okay, it adheres everywhere. It's got little villi that adhere to all sorts of structures. It's disseminated joints and skin, arthritis, so there's a lot of that, rashes, meningitis and endocarditis. It was the reason why there was so much blindness and why we started using antibiotics. First, they used silver nitrate. There's people are screened, keratitis, it was called ophthalmia neonatorum. And so now this is universally used. Strong evidence of sexual abuse. It really is. Because it should not be there otherwise. It's a gram-negative diplococcus. It's not quite a cocci as much as it's sort of coffee bean shaped with the flat insides, not the rounded outsides, but sort of the insides touching each other. It's because it can attach the fimbriae that attach. It multiplies within, slows down immunity. There's different phases that are there. Okay. Antigenic variation, something we talked about with how things confuse. Cleaves the IgA. It's nasty. So it's all sexually, it's human. Most common worldwide, as you can, and so they're looking at 2018. Notice the idea of 90% of males are symptomatic, only about half the women. And so a lot of times it's spread unknowingly, very difficult to culture. Catalase positive, oxidase positive, one of the tests. I don't know if you did that test in the lab. If you did oxidase test, it's because you use it for Pseudomonas, and it is still a reportable disease. It's becoming more difficult to treat with regard to antibiotics. Urgent threat. I'm not going to ask about the antibiotics. Let's stop there. All right. see what you guys, the people who weren't here, missed? No, I don't.